Okay, can you see my screen? Right. Okay, so for this topic, actually, this is it's like a revision of what you have learned in MNT 1, 2 and 3. Basically, dalam MNT 1, you ada belajar pasal hyperlipidemia and then diabetes mellitus. So you all dah ada dah the information about the carbohydrate modification, calorie modification, protein modification. I think for renal, you all baru belajar MNT 3 ke MNT 2 renal? Anyone? MNT 2. Okay, so kiranya untuk protein, calorie, carbo and also fat, you have learned actually. So it's more like a revision to you. Okay, and akan ada beberapa hands-on juga saya berikan. Okay, so what is it, the therapeutic diet? So it is a meal plan that controls the intake of certain foods or nutrients. So it is part of the treatment of a medical condition and are normally prescribed by a physician, but then planned by a dietitian. So a therapeutic diet is usually a modification of a regular diet. So it is modified to tailor or to fit the nutritional needs of a particular person depending on their clinical nutrition, okay, clinical situations. So the therapeutic diets are modified for mostly for three major parts, which the first one is for the nutrients, contents, for the texture, and or for the food allergies or food intolerance. So what are the reasons for therapeutic diet? Mainly to maintain a nutritional status, restore and also correct the nutritional status, to decrease the calories, control, provide extra calories to promote weight gain, to balance the amounts of carbo, fat and protein, for the control of diabetes, to provide a greater amount of nutrients such as protein, especially in a case of to promote wound healing, for example, ataupun case yang perlukan extra protein needs like for a cancer patient, and then to decrease the amount of nutrients such as sodium, exclude food due to allergies or food intolerance, to provide texture modifications due to problems with chewing or swallowing. So these are the lecture contents for today. Okay, and the first one we're going to go is the calorie modification. So basically, there are many cases actually require calorie modifications, but mainly for three purposes, whether for weight loss, weight gain, or for weight maintenance. And the cases are like for obesity, CVD, gout, cancer, post-surgery, and also burns. So these are the few formulas that we normally use to calculate energy requirements. For example, the quick method. I'm sure you all dah well versed about these kind of methods. And then Mifflin and Jaw, Harris-Benedict formula as well. And there are a lot more of formula that can be used to calculate BMR. Okay. Like Ayrton, Jones, Correri, Toronto, and even kita Malaysian pun kita ada itu Suzana punya formula, okay? And you have to count into the stress factors, whether the patient is on a ventilator dependent, which perlu masukkan the stress factor is 1.2, non-ventilated 1.0, minor operation 1.2, having a skeletal trauma 1.35, cancer, cachexia between 1.3 to 1.5, major sepsis 1.6, severe thermal injury 2.1, and also activity factors like for a resting patient 1.1, confined to bed 1.2, patient that require or have minimal ambulation 1.3, moderate activity 1.4, and heavy 1.75. But as you go through, you might find there are a lot of reference, okay, yang mana these stress factors, these activity factors might be different. So nanti you jumpa kata, kenapa buku ni tulis for minor operation 1.3 tapi Dr. Berry kata 1.2. So it's actually depending, but for your whatever methods or whatever factors that you might want to use in your case whenever calculating a protein needs ataupun energy needs, okay? You need to justify kenapa you nak gunakan that stress factor, kenapa you nak gunakan this quick method like 30 kalori per kilogram per body weight for example, okay? And then activity factors biasanya lebih kurang sama. Kalau resting 1.1 compared to weight 1.2, and then tapi kadang-kadang you akan jumpa juga heavy tu you kena tengok what kind of activities that is considered as heavy physical activity. Okay, kalau sekadar dia berlari ataupun just jogging, it's not we call as heavy. So it can go like 1.4, moderate activity. Okay, so heavy tu yang betul-betul dia marathon, yang memang sekali kalau dia run tu memang run yang, ialah dia selalu terlibat dengan marathon, and then dia memang, dia kata, kalau running tu yang betul-betul running, bukan running sekadar like a jogging up sikit, okay? Itu bukan dikatakan sebagai heavy physical activity. And then how about the weights to be used for the calculations? So this one, most of the students might get some confusions. Nak guna berat apa? Ada yang guna ideal body weight, ada yang guna actual body weight, okay? So for example, kalau healthy, the patient is within healthy weight range, iaitu 18.5 to no more than 25, so you should use the actual body weight. Kalau underweight, you also need to use the actual body weight sebab kita nak promote weight increment lah kan. And then kalau macam yang tadi, a normal BMI, kita nak maintainkan dia punya berat dia. Kalau overweight ataupun obesity, you might want to use adjusted body weight, okay? Iaitu ideal body weight tambah dengan actual body weight minus ideal body weight kali dengan 35%. Okay, and then the ideal body weight is actually the weight at BMI 25. Or sometimes there are cases that contohnya macam ni, bila you pergi jumpa patient, you tak akan jumpa dia sekali, you akan ada first time you jumpa adalah for new case, and then kalau contohnya itu adalah case untuk turunkan berat badan, which your main goal adalah to promote weight loss. So you dah kata you want this patient to lose the weight about 10 to 15% for example, okay, dalam masa 3 bulan. Okay, so you perlu jumpa dia bukan sekali, bukan jumpa waktu permulaan and then you jumpa kemudian waktu dia 3 bulan, selepas 3 bulan, tak. Bila kita manage case dengan obesity, kita kena jumpa dia periodically supaya dia tak adalah off track, supaya dia tak ada shock sendiri, tak adalah lari daripada landasan dia. Okay, so you kena jumpa, okay, first which is the more you jumpa adalah kita katakan new case, and then you jumpa lagi another 1 month, and then another 2 months, and then 3 months. So for every of the follow-ups, you need to set up your own objective. So your punya weight adjustment pun akan berbeza, and of course dia punya energy requirement pun akan berbeza, but they must have a general objective, meaning that you aim for this patient to lose sekian-sekian weight, so you berikan dia kalori 2000, okay? Tetapi being an obese patient, biasanya bila you buat that recall, dia tak akan makan dia punya dia punya intake dia 2002 saja. Dia akan makan sampai 3000, 3500, because nak naik berat badan ni bukannya sekali makan you terus naik berat badan. Okay, itu adalah fluid yang akan menyebabkan berat you berubah dalam masa very short term, sekadar beberapa hari. Tetapi kalau yang menyebabkan kenaikan berat badan, that means that this patient has been on this kind of unhealthy behavior yang menyebabkan berlakunya peningkatan berat badan dalam satu tempoh. Okay, so you kena ada satu general objective yang meletakkan bahawa saya nak letakkan this general objective adalah berat energy requirement dia 2000 ke 2500. Kalau lelaki tu 2500 lah, kalau perempuan maybe 1008. Okay, tetapi kita takkan letakkan that energy requirement untuk the short term. Short term maksudnya you akan jumpa dia dalam masa sebulan, lepas tu kemudiannya sebulan lagi, kemudian sebulan lagi. So you takkan nak suruh dia turun drastically berat capai sekian berat tu dalam masa sebulan. So that's why you kena adanya short term management and also adanya short term objective. So you nak capai for the short term, saya tak nak letak aim yang begitu tinggi, saya nak dia kurangkan 2 ke 3 BMI saja. Let's say lah you calculate dia punya BMI Encik Ali, BMI 32. So you nak jumpa dalam masa sebulan, okay? So BMI 32, cakap pakcik tu, okay pakcik kita akan jumpa lagi dalam masa sebulan. Saya letakkan ini adalah energy requirement, tapi biasanya you tak akan cerita lah dengan energy requirement sebab dia pun tak faham. You kena translatekan dalam bentuk apa makanan yang dia boleh makan, jumlah mana yang dia boleh makan ikut hari-hari, and then berat mana yang kita expect dia untuk turun. So kita expect dia untuk turun sebulan, seminggu 0.5 ke 1 kilogram. So meaning that satu bulan hanya 2 ke 4 kilogram saja. So dia perlu turunkan berat badan hanya 2 ke 4 kilogram. So could be BMI 1 point saja, turun 31 ataupun BMI 30 pun dah memadai dalam masa 1 bulan itu. So that's why you kena ada short and also long term management. Okay, you faham tak apa yang saya cuba sampaikan ni? Anyone, saya tak nak cakap seorang-seorang ya. Bila saya tanya, tolong bagi feedback. Okay? Faham tak so far?
Faham, Doktor.
Faham, Doktor? Okay. So, for the high calorie diet, it is prescribed for weight increment, especially for children with FTT, failure to thrive, ataupun teenagers with eating disorders. Internet connection is unstable. And then cancer patients, fever, hyperthyroidism, burns. So normally dia punya increment dia tu can go up to 2,000 or it could be more, depending. Okay. And then there are few ways that you can do to add extra calories instead of you bagi kat dia. Contohnya dia perlukan contohnya pesakit kanser, kekeksik. So kekeksik bermaksudnya dia turun berat badan and then dia looks very malnourished kan. Kalau kita tengok kita buat physical examination pun memang very minimal muscle mass yang present pada dia. So kita nak advise untuk high calorie diet. So bila you calculate, the high calorie diet could be 3,000 for example. Tapi takkan you nak expect this cancer patient with a lot of symptoms because of the chemotherapy yang mana menyebabkan dia akan mengalami masalah nausea, keep on vomiting, tak ada selera makan, hilang dia rasa. You nak bagi dia nasi contohnya contohnya lah nasi kan sebesar satu cawan ni hanya untuk mencukupkan kalori dia. Bila kira-kira karbohidrat dia perlu ambil pada setiap meal time 3 to 4 servings. So 3 to 4 servings, kalau kita pun yang tak biasa nak makan banyak mungkin rasa susah, apatah lagi untuk for cancer patients. So we cannot advise dia untuk ambil jumlah karbo yang banyak pada satu-satu masa, yang mana akan menyebabkan dumping syndrome dan sebagainya lah. So there are few ways that you can do to add extra calories. Like for example, you can provide smoothies. So dalam smoothies tu letaklah yogurt, and then you can add more on the for example MCT oil, okay. And then nak letak ice cream pun no problem, nak kasihkan dia sejuk, nak kasih dia ada rasa for that cancer patients for example, okay. And then kalau contohnya untuk nasi, instead of you provide plain white rice, you make it a buttered rice supaya adalah extra calories kat situ and dia lebih palatable for a cancer patients, okay. And then potatoes and starches can be added into the menu, okay. Contohnya nak buat sup cendawan, okay. Sup cendawan nak tambahkan extra calories, okay, maybe you can provide full cream milk, campurkan juga dengan potato yang di blend, and then letakkan juga dengan cooking cream. So this kind of things that you can do to provide extra calories, alright. And then add in milk, cheese and yogurt into the diet. Contohnya nak buat masak for Indian, dia punya kari dia tak ada santan, tapi kita ni nak providekan extra calories. So you can add in yogurt into the curry. So So at the end of the day, dia akan dapat extra calories. And there red meats, salmon and any other oily fish and also nuts into the diet. Contohnya daripada smoothies tadi kan. So letakkan nuts atas sebagai sprinkles. So that patient can get extra calories from the nuts, from the yogurt, from the ice cream. Okay. So these are the things that you can do to add extra calories into their diet. And how to achieve and spread the calories evenly. So again, perlu ada eat small and frequent. So you cannot just buat 3 main meals to provide all 3,000 calories. Memang tak terlarat untuk seseorang individu, especially the patient, to consume all of the meals that are provided for them. And then to choose nutrient-rich food, which covers from all food categories, to provide smoothies and shakes, which is packed of nutrients, calories and protein, and then top it off with cheese, scrambled eggs, drizzle with vegetable oils ataupun MCT oils. Okay, and you need to make every bite counts. So you need to provide them healthy snacking in between the main meals. Ada nuts, ada cheese, ada peanut butter dan sebagainya. And if the appetite is full, small servings of highly reinforced foods are given to the patients. So the diet may be modified in terms of the consistency and the flavor according to the specific needs. For the low-calorie diet, so it is prescribed for weight reduction. For example, in the case of obesity, diabetes mellitus, CVD, hypertension, gout, tak nak dia lagi burden pada dia punya lutut, okay, gallbladder disease and also following a surgery. So the characteristics of a low-calorie diet, so for the long-term objective, we want to promote a weight loss of 5 to 10% from the baseline weight within 6 months, okay? And for a short-term objective, you can say a reduced calorie diet by 500 to 1,000 calorie daily to achieve an initial weight loss of about 0.5 to 1 kilogram per week. So that is for a short-term BMI. So that you can achieve turunan berat badan BMI yang 1 ke 2 ataupun 2 ke 3 daripada initial BMI. Okay, so your punya energy requirement pun diambil kira daripada BMI yang diturunkan. Saya tadi macam saya kata tadi BMI 32. So for the short term, you punya pengiraan kalori tu adalah berdasarkan pada BMI 30 ataupun BMI 29. Okay, and then high carbohydrate 55 to 60% from the energy intake, and then low in fat which is less than 30%, high in fiber, low in GI food. Okay, because high fiber and also low GI diet is associated with increased satiety, lower postprandial glycemic response and lower the insulin level. So in a way that dia akan bantu untuk control the punya sugar levels. Okay, and then small and frequent meals. aku letak pending, but dah ke?
Dah, doktor.
Okay, so what is his BMI?
21.63.
So meaning that and 1.6, so it is a normal BMI. Okay. Alright, so we know that this patient just had appendectomy 2 days ago. So maksudnya kita boleh katakan kes ini kes apa? Dia require apa? Extra protein lagi. High calorie, alright. So have you calculated for his energy requirement? So how much you get? Satu 920. So you gunakan quick method. Yang lain, ada yang dapat lain daripada tu, you gunakan Harris Benedict ke?
Saya guna Harris Benedict tapi dapat 1,515 kcal.
That is PMR kan? So you dah count for stress factor and also physical activity?
Dah kira this is ER, dah darab dengan stress factor and the
Berapa
activity.
stress factor you letak?
Kejap. Stress factor saya letak 1.3 because it's a surgery major.
And then the physical activity?
Physical activity saya letak 1.1 sebab dia consider as bed rest lah sebab post surgery.
Okay. Tapi beza tu 1,500. Okay, yang lain ada siapa-siapa yang guna Harris Benedict? Yang lain tolong respon boleh tak? Dalam satu kelas ni ada 42 orang setakat ni dalam kelas ni. Yang saya tengok bagi respon Izzati, Fatin and then Adibah. Yang lain tak apa, saya cakap seorang-seorang ke sekarang ni? You ada buat ke tidak? Anyone? So ada seorang je lah yang guna Harris Benedict. You guna betul untuk male ke? Sebab it's a huge difference juga tu, 1,500, 1,900.
Betul doktor. Cuma I just identify balik yang bahagian height tu I forgot to convert it to inch M. I use it in
So
meter.
it's M. Itu yang selalu kadang-kadang students akan miss. Alright, so nanti you betulkan balik, okay? Okay, so kita boleh gunakan, nak senang is a quick method. So at 30 kilocalorie per kilogram body weight. Okay. And then kalau Harris Benedict, you akan dapat guna activity factor about 1.3, stress factor dalam activity factor 1.2 or 1.3 also can, and then stress factor 1.1 ataupun 1.2 also can. So you could get between antara 2,000 ke 2,200, which is not much difference dengan quick method. Okay. Alright, so next is carbohydrate modification. So there are few cases require carbohydrate modifications like diabetes mellitus, GDM, and also case of obesity. Okay, so the characteristics of carbohydrate modified diet, of course, the objective adalah to attain and maintain the blood glucose, blood pressure, lipid profile as close to normal as safely as possible, and to promote weight loss of about 5 to 10% of initial body weight over a 6-month period, which is recommended for all overweight or obese patients who have or at risk for diabetes, because we know the risk factor of diabetes is being obesity. Okay, and then the standard weight loss diet reduce the daily energy about 500 to 1,000, so that you could achieve an initial weight loss of about 0.5 to 1 kilogram per week. And then on top of that, perlu ada physical activity of 150 minutes per week, 5 sessions spread out in a week, high fiber diet, which is about 20 to 30 grams fiber. So it could come not only from the fruits and vegetables, okay, it should be more coming from the whole grain and also legumes. Okay, so kalau whole grains, it should form 50% of the total grains intake. So tidaklah kita recommend hanya white rice saja, tapi kita boleh recommendkan the whole grains into their diet, so that dia akan dapat the extra fiber. Sebabnya kalau hanya bergantung 20 grams to 30 grams, hanya bergantung daripada buah dan sayur, berapa kilogram sawi lah seseorang tu kena makan, atau berapa peratus gram sawi lah dia kena makan untuk dapatkan the extra fiber tu. So mainly untuk memudahkan, it should be coming, you should include legumes and also whole grain cereals. Okay, and then to limit the consumption of SSB less than 2 servings a day, or about 10% of the total daily calorie intake. Okay, so this sugar sweetened beverages also bersamaan juga dengan sucrose, iaitu penggunaan gula lah. So kadang-kadang gula ni kita tak guna semata-mata dalam minuman, tapi juga dalam masakan. So it's quite common sekarang ni, masakan masukkan gula, especially kalau itu adalah culture mereka. Okay, contohnya negeri-negeri belah timur, diorang biasa untuk penggunaan gula dalam dia punya masakan. So it should not be more than 2 serving. So maksudnya let's say lah, kalau 10%, okay, 10%, let's say lah kita berikan 2,000. So 10% berapa?
200.
So 200. So kalau 200 kalori, berapa serving of sugar? Satu serving sugar berapa kalori?
Satu ni ke?
Satu serving sugar berapa kalori?
Satu serving.
Saya cakap sorang-sorang ke? 1 teaspoon of sugar ada berapa gram? Assalamualaikum.
Dalam 12 doktor.
Satu
12 kalori.
satu teaspoon ada berapa gram? 5 gram, betul?
Betul.
Okay, so 5 gram is equal to
20
20
Calorie.
calories. Alah, hai you all, takkan pakai calculator. Okay, 20 calories. So, kalau saya kata 200, so maksudnya ada berapa serving yang dibenarkan?
10.
10. Tapi bukan bermaksud, yes, thank you. So, bukan bermaksud you kena gunakan 10 sudu kecil dalam masakan, dalam minuman, dalam apa. Sebabnya sugar also datang dalam pelbagai bentuk. Okay? Sebabnya saya kena bagi tahu awal, because biasanya during the therapeutic diet, I can see that it's good for you untuk kira dalam you punya meal plan tu, okay, kira berapa kalori datang daripada sugar. Tapi mostly nak menggunakan sugar. Tapi kita ni kalau boleh kita nak encourage ataupun nak educate people out there, how can you do which you still enjoy food, you still enjoy your drink, but with very minimal use of sugar, ataupun kalau boleh no sugar at all, tapi still can provide dia punya sweetness dia. So macam mana nak buat ke arah itu? Okay, so kalau nanti for your labs, if possible, avoid to incorporate sugar into the meal plan. Okay, saya nak tengokkan benda yang different. Saya nak tengok, okay, saya tak gunakan sugar dalam ni, tapi kita menggunakan natural sweetening, iaitu datangnya daripada sekian-sekian contoh. Okay, so I expect you to do this for your lab soon, insyaAllah. Okay, and then a minimum of 130 grams daily of carbohydrate should be provided to ensure adequate intake of fiber, vitamins and minerals, and also to prevent ketosis and to provide dietary palatability. Okay, so for a diabetic patient, so dia punya carbohydrate adalah between 45 to 60%, and normally it also accompany with lipid lowering diet. Okay, sama je. So you must always consider the amounts and types of carbohydrate during the meal planning as well as during the preparation. Okay, emphasize types of carbohydrate from fruits, vegetables, legumes, low-fat dairy products, and also whole grains. So the carbohydrate portions must be kept consistent on a day-to-day basis. For example, 2 to 3 exchange of cereals, grains, and starchy vegetables in the main meals, and 1 to 2 exchange during the snacking time. Okay, because we need to consider for those patients young on OHA and also in insulin regime. Kita tak nak nanti carbohydrate loading dia tu adalah, carbohydrate counting dia tu adalah berbeza. Contohnya you letakkan waktu lunch time 4 to 5 exchange, and then tiba lepas tu bila petang atau bila malam 1 ke 2, tapi malam dia kena ambil insulin. So nanti itu akan menyebabkan berlakunya hypoglycemia dan juga ketosis. So kita tak nak sebenarnya berlaku macam tu. So you need to have a consistent on a day-to-day basis of carbohydrate counting. And then for the dietary fiber, the good sources of fiber include whole grains, vegetables, fruits, legumes, seeds and nuts. So there are few ways or tips to increase fiber intake into the diet. For example, to choose whole grain products such as brown rice, wholemeal bread, oatmeal biscuits, and to choose whole fruit instead of fruit juices. I think you know better about this. And also to include vegetables in every meal. So lentils, milk and yogurt also contain a significant amount of carbohydrate, which you need to take into consideration during the meal planning. Dia ada juga contribution of carbohydrate. And then protein food should not be used to replace carbohydrate to achieve weight loss and also blood glucose control. Okay, next is protein modification. Okay, so it is a modification from a normal diet. It could be increased or decreased protein requirement, and the micronutrients content should be close as the recommended requirement as well. So these are the cases require protein modification, like for example CKD, nephrotic syndrome, cancer, and also patients who undergone surgery. And the characteristic is that for the high biological value protein should consist more than 50%, and it should be more coming from the unsaturated fats than the saturated fats. For example, untuk high protein diet, which more kalau normal protein intake adalah 0.8. So kalau high protein diet, it is more than that. Okay, biasanya more than 1.0. So it may be prescribed for a variety of conditions like diarrhea, bleeding, cancer, burns, malnourished, elderly dan sebagainya. Okay, and then for a case of low protein diet, it is usually prescribed for conditions like hepatic encephalopathy, acute and chronic glomerulonephritis, nephrosclerosis, acute and chronic renal failure, and also IEM. So, in chronic liver disease, okay, just now I said that low protein diet is prescribed for those who have a problem with their liver. Okay, so normally, in chronic liver disease, the protein can be used for the synthesis. So the amino acids will be catabolized, and excess ammonia cannot be converted to urea for the excretion, and the patient might develop hepatic coma. So previously, protein levels must be decreased or completely restricted for a few days. Okay, however, it is found that malnutrition became prevalent for chronic liver patients, especially those who have compensated liver cirrhosis. So for those who have a compensated liver cirrhosis, they might require a protein of 1.2 to 1.5, and patients, chronic liver disease patients who look malnourished ataupun daripada dia punya physical examination, daripada dietary intake memang very poor, daripada biochemical profiles also very poor, so you could give them between 1.0 to 1.8 gram of protein per kilogram daily. Okay, and the protein needs are higher also in malnourished and the presence of the bleeding, infections, or surgery. So how about patients with kidney disease such as acute and chronic glomerulonephritis, nephrosclerosis, acute and chronic renal failure, which require low protein, which between 0.6 to 0.8, because the kidney cannot excrete the nitrogenous waste. So the diets containing should be contain 18 to 22 grams coming from the HBV. Okay, but for patients on dialysis, whether HD or PD, they require a high protein diet, which could be between 1.1 to 1.3. Okay, so these are the characteristics of renal diet, which the objective is to delay the progression of kidney failure, to maintain a good nutritional status in preventing malnutrition, but by giving adequate amount of protein and energy, and ensure that there is a sufficient nutrients such as calcium, ferrum, and other vitamins and minerals, to minimize electrolyte and mineral disturbances, okay, which is quite common among kidney failure patients. Encourage physical activity so that we might want them to build up more muscle mass, okay, and then to control food intake whenever necessary to prevent and manage comorbidities such as CVD, anemia, bone disease, and also diabetes mellitus. Okay, so these are the nutrition prescription. I think I don't have to explain more about this, but you need to keep in your mind that whenever a patient is given low protein diet, so biasanya akan ada problem low protein ataupun high protein diet, biasanya akan ada problem dengan phosphorus. Okay, so phosphorus level adalah salah satu biochemical profile yang you need to take into consideration, and also you need to monitor for a renal patients. So biasanya bila kita limitkan atau bila kita tingkatkan the protein intake, dia punya phosphorus level of also you need to look into. Okay, and also untuk patients yang renal patients, biasanya kita kena control dia punya sodium. Okay, so bila kita control dia punya sodium, potassium pun perlulah rendah. Tapi potassium ni mainly coming from the fruits and vegetables, okay, the fresh food. So macam mana you nak make sure that this patient is still benefit from the high protein diet, for example, kalau untuk pre-dialysis, tapi dalam masa yang sama you kena control dia punya potassium dia. Okay, so dan dalam masa yang sama you nak encourage pula high fiber diet for that patients. So these are the tricky parts in managing renal patients. Okay, and then next is gluten-free diet. Okay, so in celiac disease, which the protein gluten in wheat and rye brings out a metabolic effect in the intestinal mucosal cells. So the protein gluten is composed of two fractions, glutenin and gliadin. So the latter protein, which is the gliadin, cause the difficulty, especially for the celiac disease patients. Okay, so the treatment involves the removal of this protein from the diet, so which is what we call as gliadin-free diet, and also could be called as gluten-free diet. So you need, the main point is to exclude food containing gluten. So the purpose to manage the signs and symptoms of celiac disease and other medical conditions which is associated with gluten. So other conditions that might require gluten-free diets apart of celiac disease, for example, those who have sensitivity towards gluten but not having a celiac disease, and then those who have wheat allergy and also gluten ataxia. So the characteristics of gluten-free diet is that they should be allowed to consume fresh food, which coming from the fruits, vegetables, beans, seeds, legumes and nuts in their own natural unprocessed form. Bukan dalam bentuk yang dah proses, contohnya yang dijual dekat stesen minyak ke kan, you know, dalam small packaging, so dia beli dekat situ just because kata boleh makan legumes and nuts, tapi dia ada dalam bentuk yang dah diproses. And also eggs, lean and non-processed meats as well, and also the starches. Starches yang dibenarkan adalah rice, quinoa and also tapioca. But these are the grains that they do not allowed to consume in any form, whether in a form of food or drinks, which are wheat, barley, rye, triticale and also oats. So the reason why oats also should be omitted, because during the process of oats, okay, so there might be a contamination of wheat, barley or rye. Okay, sebab rupa mereka adalah lebih kurang sama. So during the production mungkin akan berlaku contamination. So it is better for patients who need a gluten-free diet to avoid oats as well. And then low protein diets are also prescribed for patients with inborn error of metabolism as a result from the lack of enzymes in the urea cycle, in which the amino acid content cannot be metabolized normally, and as a result other metabolites are accumulated which are toxic. So in such cases, the amino acid from the diet is either should be decreased or completely eliminated. For example, patient who have phenylketonuria, yang mana amino acid yang terlibat ada phenylalanine, homocystinuria, hypervalinemia, like the amino acid yang terlibat adalah valine. And then for a treatment of MSUD, macrocystic urine disease, it is quite difficult because the amount of the 3 essential amino acid must be regulated, which are valid leucine and also isoleucine. So in Malaysia, normally, if you have the chance one fine day kan, kalau diberi, but now we don't have any MOU dengan HKL. So kalau bukan HKL, apa tu, hospital kanak-kanak, wanita dan kanak-kanak Tengku Ampuan rasanya, HTAA dekat HKL. So di situ dia ada ward pediatrik yang menempatkan kanak-kanak with problem of inborn error of metabolism. So dekat situ you akan jumpa pelbagai inborn error of metabolism yang you tak pernah jumpa. Biasa kita selalu dengar phenylketonuria, that is quite common. PKU ataupun MSUD, that is quite common. Tapi ada juga kes-kes yang sangat rare, tetapi mereka akan biasa kelompokkan dekat situ. And these pediatric patients, they require a special formula milk, yang mana these children still require milk, tapi milk also contain amino acids. So their special formula milk perlu omit certain type of amino acids. So dan juga susu dia tu very small, kecil je, tapi memang sangat mahal. Itu yang saya boleh katakan. Kebanyakan kes-kes tu datang daripada golongan-golongan like B40 ataupun golongan yang datang daripada yang pedalaman yang susah. But Alhamdulillah lah, KKM still can provide dan juga berikan subsidi kepada most of the parents so that their children still can consume milk, which is part of their important nutrients untuk their own growth and development. Okay. Alright, so next hands-on session adalah this one saya dah berikan siap-siap. Okay, this one adalah stage 2 CKD yang mana dia require 0.8 normal protein requirement, pre-dialysis yang mana dia require 0.6, okay, and then hemodialysis patient which dia perlukan 1.3 high protein diet. Okay, so given here adalah weight of this patient. Okay, kita imagine lah this patient dia adalah orang sama yang mana akan melalui stage 2 CKD, kemudian pre-dialysis bila dah end stage, and then also hemodialysis. So berat dia adalah 70 kilo. So saya berikan siap-siap dia punya energy requirement dia perlu adalah 35 kilokalori and also carbohydrate at 55%. So I want you to write down what are the protein requirements, how much should be given for the carbohydrate, how much of the servings per day, and also for the fat as well. And then show to me your example of meal plan just for the protein only. Okay, so I give you 15 minutes to complete this task.
Fat tadi berapa persen dia cakap?
Tak dapat.
Oh my.
Sorry, I nak tanya, kelas rep ya kan?
Bukan saya, doktor. Saya doktor.
Oh, Cinderella. Okay.
Open calculator. Semua. Eca, fat berapa? Eca, fat. Kau dapat protein berapa?
Yang stage 2 tu dapat 56. Yang 2 tu dapat 42.
Karbohidrat ni? Karbohidrat tu ya?
Karbo tu aku dapat 336.
337.
337.
Fat, darab.
Fat tu aku dengar macam something 5. 35 tu 45. 35 macam banyak sangat.
Itu bawah tu.
Yang fat. Doktor mention ke fat berapa?
Tengoklah balik
Kalau
record.
saya balance protein dengan carbs aku buat macam tu. Aku dapat 97 untuk sehari. Satu lah nak bagi dia makan apa.
Makan legumes dan juga next sensation adalah this one is yang mana the requirement here adalah weight of this patient, age, and then also hemodialysis. So berat dia adalah 70. So saya berikan siap-siap dia punya energy primary group adalah 35 kilocalorie and also carbohydrate at 55%. So I want you right, and then protein requirements. How much should be given for the carbohydrate? How much of the servings per day, and also for the fat as well. And then
Tak ada for the fat as well. Jangan gerak.
yang aku tak kira lagi. Aku tak kira lagi protein. Yang ni guys. Yang atas tu aku dah tahu.
Aku dengan kalkulator tadi lagi lembab.
Okay, dah boleh dah? Dah siap semua?
Belum.
Dah siap ke?
Tengah buat main plan, doktor.
So I give you another 5 minutes.
Tak sure.
Allah.
Aku rasa Benny Maestro okey bawah tu yang rebus tu.
Waduh.
Okey, dah siap? Namanya. Okay, Daya, dah lama sangat dah ni. Okay, for protein requirement, stage 2 CKD, berapa you dapat? Nurul Zahira?
Sudah, dipanggil nama. Sudah.
56 gram.
56 gram. Yang lain? Sama doktor. Okay, untuk siapa saya tak tahulah nak cakap kan. So it should be direct lah. Okay, pre-dialysis, Fatin Aisyah.
Takut dia patin. Patin takut Aisyah.
Fatin Aisyah, pre-dialysis.
42 gram.
42 grams. Hemodialysis, Nur Syafiqah, Muhammad Fauzi.
91 gram.
91 gram. Okay. So for the carbohydrate, stage 2, Nur Najiha.
Apa kau dekat mana?
Nurul Najiha.
Tak, yang lain, yang macam yang pre-dialysis dengan hemodialysis kau.
One more time, Nurul Najiha.
Tak, yang kau tadi kau pandai kau cakap lain kan?
336.8.
336.8 gram.
Kau sama je.
Is it gram?
Sama kan?
Yes.
Berapa serving?
Oh, dia tanya serving pula.
Bateri nak habis. Dia tahu exchange. Dia tak tahu serving. Janganlah tanya serving. Serving tu jadi apa? Aku serius ada
Berapa
question.
serving? Okay, anyone? Siapa boleh jawab kan? Berapa serving?
17 kot.
22 serving. Betul tak doktor?
22 serving. 22 serving. Is it mengambil kira protein?
Tak.
You tak kira, you tak tolak daripada situ lah.
Bahagi dengan 15 gram karbohidrat.
Oh, you directly bagi. Okay. Alright. Pre-dialysis?
Sama. Bagi 15 gram
Pre-dialysis
lah.
Nurul Syazwani.
gram.
Yang lain sama?
Same lah, same.
Sama doktor.
Hemodialysis? Hemodialysis.
Karbohidrat zat dia sama juga doktor, macam 336.9.
336.9. Okay. You all kira daripada berapa kalori? Total kalori?
2450 kalori.
Semua orang pun 2400. You choose 2400.
Betul.
Okay, because I already put there 35 calorie. Okay, right? And then, okay, so it should be direct lah. Okay, how about fat? Fat ni I'm sure mesti ada perbezaan kan?
Betul.
Okay, fat. Syahidah Abdul Rahim.
Untuk yang stage 2, fat 98 gram.
98 grams. So berapa serving? You jangan bagi directly tau. You tahu kan kalau nak buat meal planning macam mana? You kena tolak daripada karbo, kena tolak daripada protein, right? So you all semua directly bahagilah ni. Semua buat macam tu ke? Yang lain-lain? Yes.
Yeah.
Okay. Alright. Okay, tak apalah. So kita assume you all directly bahagi, tapi sepatutnya untuk menu planning bukannya you kena buat jadual, betul kan? Right?
Betul.
Okay, so sekarang ni saya tutup mata. So okay, fine, kita directly bahagi 98 gram. So berapa persen tu?
36.
36%. Okay, and then for pre-dialysis, Emmanuel.
Kenapa 36?
Ada ke tak ada? Emmanuel, pre-dialysis
Aku guna
untuk
20
fat. Ada sesiapa yang sebilik dengan dia? Ni hadir ke tak hadir kelas ni?
Dia macam nak kira fat.
Kalori fat tu bahagi dengan total kalori.
Okay, I'll take note on that. Farah Nadia.
Macam nak tahu berapa persen?
Betul.
Berapa gram?
For pre-dialysis, 103.8 gram.
100 apa? 3.8. Okay, so berapa persen?
Ay,
4%.
ha?
4?
Sekejap.
Mana boleh 4%?
Sekejap, doktor, saya cuba kira.
Bukan fat 20 to 35 ke? Macam mana boleh 36 ni? Penting lah.
38%.
38%. Yang lain sama?
Sama.
Okay. And then for the hemo.
Faham. Berapa?
81.67.
81? Fat? Oh, it's gram, sorry. Gram, okay, dia punya percentage?
30%.
30.
30. Sekejap, yang tadi 90, sekejap 38%. So, protein untuk pre-dialysis berapa persen yang dapat? 7, betul. 7, betul. Untuk stage 2?
Stage 2, 9.
9%. Semua pun dapat sama
Lepas tu
Sama.
56 gram ni
Okay,
kan
good.
protein kan.
Alright, so now we go to the next one, which is example of meal plan, which yang I nak tengok adalah for protein
So
only.
aku tahu lah berapa kekal untuk protein.
So
Lepas tu
berapa,
karbo pun aku dah
this one you need to consider
Dia akan tahu total
50%
kalori
HBV,
berapa.
walaupun tadi you
So,
kira,
nanti
let's say you dah
tolak-
dapat
tolak
tadi
ni,
untuk protein
dapat berapa-
56 gram kan,
berapa ribu
untuk
kalori
yang
untuk
stage
fat.
2.
So, aku bahagi
So
dengan
50%
9.
HBV berapa? 28 gram, betul?
Apa dia?
Kan?
Apa doktor cakap?
Betul tak?
Betul.
Okay, so berapa you letakkan untuk setiap waktu makan ni?
Soalannya apa weh?
Amira Afifah, boleh tak you present apa yang you dah buat?
Present.
You just briefly bagi tahu buka present.
Doctor, can you repeat the question?
Dah dengar lah, Amira.
Hello?
Ya. Okay, berapa? Yang you nak berikan?
Can you repeat the question again?
Maksudnya saya nak tahu breakfast tu apa yang you nak berikan.
Berapa
Serving
apa?
size dia macam mana?
Okay, I plan like for breakfast. Breakfast 1 serving size.
Of?
Lunch 3 to 4.
3 to 4
And then of
Protein.
instead of protein.
I think maybe
And then
your line is not clear lah,
3 to 4
Afifah.
juga.
3 to 4.
3 to 4 serving.
Protein.
Yeah,
Protein
I'm
ke
so sorry.
karbo?
Sebab apa?
3 for 3 for lunch and dinner.
Protein ke karbo?
Oh,
Yes.
I see.
Protein.
Protein. Takkan 3 to 4?
Protein.
Are you sure this is how you calculate?
Okay, 3 lah. Okay, lunch 3, dinner 3, breakfast.
Okay, total protein dia 56 gram. So kalau you kata breakfast you bagi 3 servings which equals to 21 grams. And then lunch 21 grams
No.
sama. Betul? Okay dah. Okay, tak apa. Aina Nadra, can you please help your friend and present what you have?
Saya guna exchange.
You guna apa?
Exchange. So kalau macam breakfast tu boleh ambil egg sandwich. Consists of 1 to 2 medium egg.
Satu ke dua?
Exchange protein.
1 medium egg.
Okay, so 1 medium egg is 1 serving ke half?
1 exchange. So 1 exchange so ada
Exchange.
35.
You all jangan confuse dengan serving and exchange
Ah,
Dia ada dua benda yang berbeza. Tahu kan?
tahu.
Okay. So 1 exchange untuk breakfast. Telur, okay? Which the 7 grams. And then lunch?
Lunch chicken rice. So untuk chicken tu pun 1 exchange juga.
Okay, so 7 grams. 14. And then dinner?
Dinner fresh milk half cup. 1 half cup.
Sudah minum susu je? You nak dia minum susu je?
Untuk protein lah maksudnya macam untuk karbo
Baru 21 grams, you tak capai 50% HBV ni. Ingat tak saya kata, kalau untuk kes yang melibatkan especially low protein diet 50% HBV you kena ingat. So kalau you letak lah, biasanya 0.8 dan ke bawah tu dah dikira low lah, walaupun 0.8 tu normal. Tapi kadang-kadang this CKD patient dia datang dengan dalam keadaan yang malnourished. Okay, dan kita tak boleh nak berikan terlampau tinggi protein sebabnya kidney dia tak, orang kata memang dah malfunction lah. Alright, so kita bagi dia 0.8, but you need to ensure that they achieve 50% HPV. 50% datang daripada HPV. So kalau kita bagi kat sini 56 gram, so 28 gram perlu datang daripada HBV, and the rest could be datang daripada carbohydrate. Kan bila kita kira karbohidrat kan ada small percentage untuk protein kan, so that is like the low BV one. Okay, tapi untuk HBV kena ada 50%. So kat sini kalau you beri kat saya tadi baru 21 gram, so you should include another one exchange of protein yang high biological value lah, ikan ke, daging ke. Okay? Alright. Okay, so now the trickiest one, the pre-dialysis. Okay, pre-dialysis saya nak Izzati.
Ya, doktor.
Okay, so total protein ada 42 grams, betul?
Betul.
Okay, so berapa persen HBV?
24
Berapa gram daripada HBV?
24 gram.
24 grams yang you dapat kira.
Yes.
Okay, great. So berapa you nak bagi distribution dia?
Saya guna exchange juga, doktor.
Okay, yes.
So, kita ada 6 exchange. Okay, untuk breakfast HBV dia low, tapi untuk lunch dengan dinner high. Okay, cik. Tapi sama je, semua 2 exchange for breakfast, 2 exchange for lunch, 2 exchange for dinner.
Okay.
Okay.
Dah. Alright. Okay. So, okay, thank you Izzati. So this one, it looks simple because it's on you just roughly tulis tau dalam notes. Tapi in the practice, during the practice, you might find this case is tricky. Sebabnya you perlu account for carbohydrate. Okay, daripada carbohydrate adanya protein, adanya fat. So dekat situ you akan dapat, bila you calculate, maybe you tak susah untuk nak capai 50% HBV tu.
50%.
Okay? Faham tak maksud saya?
Apa sini banyak sikit.
So for that, kita nama pun namanya therapeutic diet modification, therapeutic diet preparation. So you need to find carbohydrate yang low protein. So itu cara dia supaya dia takkan mengganggu. Maksudnya bila you calculate nanti, carbohydrate you automatic bila dah you punya low protein kan. Kalau itu tadi untuk pre-dialysis hanya ada 7% saja datang daripada protein. So the rest daripada carbohydrate dan juga fat. So fat tadi kira 38%. Carbohydrate 55%. So bila kata 55%, maksudnya it's a big number. Okay, kalau 50%, sebabkan 50% tu dari yang tinggal berbaki protein hanya 7% saja. So 55% karbo ni tadi daripada out of 2,400, dia akan menjadi serving yang sangat banyak. So bila serving tu banyak, dia akan mengambil portion bahagian protein. So dekat situlah kita katakan sebagai LBV. Tapi kita punya aim untuk case renal, you need to achieve at least 50% coming from HBV. So as I said, this is the tricky part, yang mana kita nak tengok when the actual time, bila you nak manage for your lab nanti, kita nak tengok berapa yang you dapat. Macam mana you nak selesaikan masalah ni. Low protein is given, and then automatically carbo and fat akan naik. So of course serving untuk karbo akan tinggi, dan juga dia akan mengambil portion daripada protein tadi, tapi dia bentuk LBV. Tapi dalam masa yang sama you nak kena provide HBV. So dekat situlah you kena bijak untuk memilih karbohidrat yang low protein. Okay. Alright. So hemodialysis berapa gram kita dapat tadi? Berapa tadi gram? 5. Hemodialysis 84 gram Betul tak? 80 berapa? 90 berapa? 91 gram. So untuk high protein biasanya you takkan ada masalah untuk nak pembahagian protein exchange ni. Biasanya 0.8, 0.6, 0.75 you akan ada masalah tu. Okay, so for hemodialysis tak pernah saya tak proceed. Sebab biasanya kita takkan ada masalah pun. Alright. And then kalau tengokkan percentage of protein pun almost macam normal lah for normal one. Okay. Alright, so sekarang pukul berapa dah ni? So kita teruskan. Okay, the last one is fat modification. So we know that fat is an essential nutrient and its dietary level should not fall too low. Otherwise, the diet that you prepare will become monotonous, low palatability, low energy density, and the amount of essential fatty acid can be limited in the overall diet. Okay, so fat modifications can be low fat diet ataupun heart healthy diet. So these are the cases that require fat modifications like CVD, obesity, and also chylothorax. Okay, according to RNR 2017, so the recommended intake for fat is between 20 to 35 and the upper limit adalah 30%. Okay, and the upper safe limit adalah 35% total energy intake for active adults. So the saturated fatty acid should be less than 10% from the total energy intake. MUFA between 12 to 15, PUFA between omega-6 PUFA between 3 to 7, omega-3 PUFA between 0.3 to 1.2%. And at the moment, there is no recommendation for the limits on dietary cholesterol intake for a healthy population. Previously adalah not more than 200 milligram of cholesterol.
Total energy intake.
But many studies proven that dia kata kolesterol ni bukanlah penyumbang utama kepada penyakit jantung. Dia ada datang daripada trans fatty acid, contohnya saturated fat, itu adalah antara penyumbang kepada masalah jantung. So saying that there is no limit, but however kita tetap perlu educate the public about how much for a certain food contain cholesterol. Sebab kita tak nak they are all over consume of this cholesterol in the diet. Okay, and then trans fat should be less than 1% of the total fat intake. So for fat-free diet. So this one is meant for patients with chylothorax. So the goal is to decrease the production of chyle fluid to prevent malnutrition. So what is a chylothorax? Chylothorax is a leakage of chyle, which is a type of pleural effusion. So there is a collection of chyle in the pleural cavity, which result from the leakage from the lymphatic vessels, usually datang daripada thoracic duct. So it occurs when the fluid that digests fat, builds up around the lungs. So what happen adalah dia akan mengganggu pernafasan. So dietitian plays an important role to prevent the malnutrition and also to minimize the chyle production and the flow. Okay, next. So the aim of this fat-free diet is to reduce the flow of chyle through the thoracic duct while waiting for spontaneous healing. And then this thoracic duct chyle flow increase after eating, particularly after a high-fat meal. So this volume of chyle flow can be reduced by avoiding fat-containing enteral nutrition. So therefore, a complete oral intake cessation should be commenced and with TPN or a low-fat diet. Okay, so fat-free diet plus MCT is recommended for them because it will be absorbed directly into the portal venous system bypass the lymphatic drainage. And then next is the under-lipid lowering diet, which is according to this European guidelines on cardiovascular disease prevention in clinical practice. So yang mana healthy diet is recommended as a cornerstone of CVD prevention in all individuals. Okay, and what are the characteristics of healthy diet? Which the first one, saturated fatty acid to account less than 10% through replacement by PUFA, and then trans fatty acid should be consumed as little as possible. Preferably, no intake coming from the processed food and only 1% of total energy intake coming from the natural origin. And then not more than 5 grams of salt intake per day. Fiber 30 to 45 grams, preferably from the whole grain products. To consume fruits about 2 to 3 servings. Vegetables 2 to 3 servings daily, and then fish 1 to 2 times per week, especially the oily fish, and 30 grams also should be coming from the unsalted nuts every day, and the consumption of alcoholic beverages should be limited to not more than 2 glasses per day for men and 1 glass per day for women. So sugar sweetened soft drinks and alcoholic beverages should be discouraged. So kat sini kalau kita tengok memang tidaklah mereka bercerita berkenaan dengan kolesterol. Okay, and for the body weight, so it is recommended that they need to achieve and maintain healthy weight. Okay, because it is associated with a reduction of dyslipidemia, hypertension, risk of developing type 2 diabetes, and also it will improve the cardiovascular risk profile. Okay, this one sama je. Okay, berkenaan dengan trans fatty acids. So, according to a meta-analysis of a series of prospective cohort studies, it's shown that on average, a 2% increase in energy intake, which comes from trans fatty acid, will increase the cardiovascular disease risk by 23%. So it is recommended to derive less than 1% from trans fatty acid every day. So now kita didedahkan dengan a lot of fusion food, a lot of viral food. Apa lagi? Apa bukan viral, kita panggil apa tu? Yang you know, there are a lot of food sekarang ni yang semua benda nak dicampurkan dengan cheese, semua benda nak dicampurkan dengan mayonnaise. Kadang-kadang tu benda tu macam sound ridiculous and it looks geli lah kan bila tengok semua benda di-cheesekan dan dibubur mayonnaise dengan banyaknya. Dan juga belum lagi dengan a lot of food yang melalui pelbagai proses, contohnya nugget, fries dan sebagainya. So ini yang meningkatkan the intake of trans fatty acid for all of us especially. And then this one dia kata, okay, the impact of dietary cholesterol on serum cholesterol level is weak compared with that of the fatty acid composition of the diet, which trans fatty acid, saturated fatty acid. Okay, so when the guidelines are followed to lower the saturated fat intake, this usually also leads to a reduction in dietary cholesterol intake. Eventually dia akan berjalan seiringan. Okay, so therefore some guidelines on healthy diet do not give specific guidelines on the intake of dietary cholesterol, but it is recommended to consume a limited intake of 300 milligram daily of dietary cholesterol. And how about fiber? A recent meta-analysis of prospective study showed that 7 grams per day of higher intake of total fiber is associated with a 9% lower risk of cardiovascular disease risk, and a 10 grams higher fiber intake is associated with a 16% lower risk of stroke and a 6% lower risk of type 2 diabetes. So, high fiber, as a conclusion, high fiber intake reduce postprandial glucose response after carbohydrate-rich meals and will lower the total cholesterol and LDL-C levels. So recommendation on fish, it says that it has a protective effect on CVD, which attributed from the omega-3 fatty acid content. So from a pool risk, estimate that eating fish at least once a week will result about 16% reduction in the risk of cardiovascular disease risk compared with those who eating less fish. And a recent meta-analysis showed that eating fish 2 to 4 times a week reduced the risk of stroke by 6% compared those who eating fish less than once a week. So, again, we need to eat more fish as compared to red meats ataupun seafoods ataupun chicken. Okay, next adalah Mediterranean diet, which comprise of many of the nutrients and foods that highlight on the high intake of fruits, vegetables, legumes, whole grain products. Olive oil is an important source of MUFA. Eggs are consumed 0 to 4 times a week. Moderate consumption of alcohol, which mostly coming from the wine. And then low consumption of red meat, dairy products, and also saturated fatty acids. So a meta-analysis of prospective cohort studies demonstrated that greater adherence to a Mediterranean diet is associated with a 10% reduction in the cardiovascular incidence or mortality and an 8% reduction in all-cause mortality. So in an RCT or randomized controlled trial among high-risk individuals suggests that following a Mediterranean diet over a 5-year period compared with those who are on a controlled diet was related to about 29% lower risk of cardiovascular. Okay, so this one I rasa masa pun dah 2 hours. So this I will put in the learning activities. Okay, so you should try to complete before before Friday. Okay. Alright. Any questions? Kalau tak ada soalan, I should end this class and thank you very much everyone. So later I will share these notes and also this tutorial in the learning activities. Okay, Assalamualaikum.
Thank you so much, Doctor.
Thank you, Doctor.
Thank you, Doktor.